Hello everyone, a warm welcome to the latest instalment of the CDX Engage webinar series hosted by Angle. Immune checkpoint inhibitors in circulating tumour cells, the potential for real-life monitoring of response. This webinar is set to explore the numerous opportunities for CTC analysis to advance the provision of a personalised healthcare approach from bench to bedside. My name is Fanula and I'm the bespoke event producer for the CDX Engage portfolio at Hanson Wade, and I will be chairing the session today. Today, I'm delighted to say that we are joined with a fantastic speaker, Dr. Melanie Janning, a clinician at Hamburg University. The presentation portion shall last 25 minutes and will be followed by a quick poll and then by roughly 10 minutes of audience Q&A. Please submit all questions via the questions tab at the bottom of your webinar dashboard. We will endeavour to answer all questions in the allotted time, and all unaddressed questions will be passed on to Melanie, so if we do run out of time, we can follow up with answers directly. Without further ado, we will begin the session. Now, over to Melanie, who will start by letting you know a bit about her work and follow with her presentation, Immune Checkpoint Inhibitors in Circulating Tumour Cells, the potential for real-life monitoring of response. Over to you, Melanie.
Hello, everyone, and a warm welcome from my side as well. I am a resident here at the University Hospital in Hamburg-Eppendorf at the Department of Oncology and Hematology. And since the last 2 to 3 years, my main clinical interest has been in patients with thoracic cancers. I also have a very strong research interest, and I work in the group of Professor Sonja Loges. And in this group, one of the main research interests is in understanding or better understanding mechanisms that lead to resistance towards different cancer treatments. And ideally to use this information to even develop new treatments and also to guide treatment strategies. And we are also affiliated to the Institute of Tumor Biology. And here, Professor Pantel and his colleagues, they have a great and long-lasting experience in liquid biopsy. Today's talk, I will focus mainly on circulating tumor cells in non-small cell lung cancer. But before we go there, I would like to give you a short introduction into lung cancer. In terms of incidence, lung cancer actually has the highest incidence in male and the second highest in females after breast cancer. But if you look at the mortality, you can see that it actually has the highest mortality rates both in males and in females. And if you then look at the overall survival, which is depicted in this graph here, according to the different tumor stages, you can see that for patients with stage 4 advanced and metastasized lung cancer, that these patients have really very poor prognosis, and you can see that the mean overall survival is around 9 months or less. At this point, I have to say that these data were collected from patients that were diagnosed between 1992 and 2010. So I believe that one of the main reasons why outcome has been particularly bad, especially also in lung cancer, is that for a very long time we really did not understand very well the huge heterogeneity between patients, even if they have the same cancer, for example, adenocarcinoma of the lung. So for a very long time we treated all these patients with the same drug. And you can imagine that in this very heterogeneous group of patients, there were some patients that actually responded to these drugs. There were also patients where this drug didn't have an effect at all, but we also had patients where the drug that we chose actually had an adverse effect on the outcome of these patients. So ideally, we would like to be in a situation where we can really choose the right drug for the right patients in order to maximize outcome, but also to improve quality of life for our patients. And in order to achieve that, we really have to understand what is driving each patient's tumor on a molecular level. And this includes genomic changes, for example, like identification of driver mutations, but this also includes transcriptomic changes and proteomic changes that are driving tumor progression. But when it then comes to choosing the right treatment, we also cannot forget and cannot only rely on the information that the tumor is giving us. We also have to look at the patient itself, and this is depicted by the little stethoscope you can see here on the right side. So we have to also look at the factors that the patient is bringing into the equation. And this can be the age, this can be the gender, this can be comorbidities that the patient might have and that might actually interfere with the choice of treatment that we would actually prefer. But this in the future can also, for example, be things like the gut microbiome. So I think that all of this together is actually what precision oncology is about. And in the last 10 to 15 years, we have really made some improvement with this in non-small cell lung cancer. One thing that we understood is really, or better understand now, is really the genomic heterogeneity. And this is something that's depicted in this picture here. So we really were able to identify targetable driver mutations in both adenocarcinoma and squamous carcinoma patients. This is what you can see here. So almost 60% of the patients with adenocarcinoma actually have, or in these patients, we were actually able to identify driver mutations. And with the orange stars here, I have indicated mutations or aberrations for which we have drugs already available in the clinic. And with the yellow stars, you can see drugs that are in early clinical testing. And you might wonder how this actually improves treatment. So we really learned that when we give patient with a specific driver mutation a drug that is specifically designed to inhibit that specific driver, we can really improve outcome for these patients compared to what we did before, that was giving chemotherapy. And this is a little example that you can see here. This is from the ALEX trial, and in this trial, patients with ALK fusions were treated with alectinib, which is a second-generation ALK inhibitor, compared to patients that were treated with crizotinib, which is like which was the first ALK inhibitor that was in the clinical trial. And you can see here, this is progression-free survival, that when you treat these patients with alectinib, the mean progression-free survival is actually almost 35 months. And if you compare that to the 9 months you saw on the graph in the slide before, you can really appreciate that we really improve outcome, or can really improve outcome for these patients. Another major improvement is coming from the identification and the influence of immune checkpoint inhibitors on tumor development and tumor progression. And this is depicted in this picture here. So here are shown the CTLA4, which is on the top part here, and the PD-L1 checkpoint, which is on the bottom part here. You can see this here. And for basically what is happening is that for a T cell to decide whether it's going to be activated or not activated is depending on some co-stimulatory or co-inhibitory signals. And co-inhibitory signals are, for example, the CTLA4 checkpoint, but also the PD-L1 checkpoint. So basically on the top part, you can see that the via the CTLA4, basically an inhibitory signal is transduced to the T cell, which makes the T cell basically resting and not active. And with regards to PD-L1 is that if you have an antigen experienced T cell, and that's sort of in the tissue, then for the tissue, if it sort of wants to stop the inflammation, because you cannot have continuous inflammation, at some point the inflammation has to stop. The tissue, for example, starts to expresses PD-L1 or PD-L2, which then binds to PD-1 on the T cell, and this then leads to an inactivation of the T cells, and thereby to a stop of the immune response. But what happens in the tumor is that this tumor, especially in non-small cell lung cancer, they hijack this system, and they also express PD-L1 and PD-L2, so that when a T cell that actually identifies the tumor cell and wants to sort of eat it up and say, you're wrong here, you need to go away, I have to sort of eat you up, that then this T cell finds PD-L1 or PD-L2, and then it's actually activated and cannot really fulfill his function in actually eating up, as you might say, this tumor cell. And as you're well aware, treatments or antibodies that are blocking these interactions both on here and here have been developed recently, and in non-small cell lung cancer, especially the PD and PD-L1 inhibitors have been quite successful. So for patients that have non-targetable or that don't have any targetable driver mutations, as so-called non-driver NSCLC patients, we have different options as first-line therapy in the clinic now. So for patients that have a PD-L1 tumor proportional score, this is what the TPS stands for, above 50%, that means that in a tumor tissue biopsy, you have more than 50% of the tumor cells expressing PD-L1. This study showed that actually by treating these patients with pembrolizumab compared to chemotherapy, that these patients that were treated with pembrolizumab have a huge survival advantage. So for patients with a PD-L1 tumor proportional score above 50%, we could choose to give an immune checkpoint inhibitor alone. And this study here compared pembrolizumab in combination with chemotherapy, where this chemotherapy alone, and it also showed, independent of the PD-L1 status, that the combination of immunotherapy plus chemotherapy hugely improved outcome for these patients. And this is pembrolizumab is not the only option here. You could also give, for example, atezolizumab, but we could basically also give these patients immune checkpoint inhibitors plus chemotherapy. And a recent study investigated whether two different immune checkpoint inhibitors combined, in this case nivolumab and ipilimumab, compared to chemotherapy, also had a survival advantage, and they could really show that ipilimumab and nivolumab also improved overall survival compared to chemotherapy. So there may also be, probably in the future, a third option which we have choose for our patients. So the situation is not becoming any easier. So in order for us then to choose the treatment for the patients, we need a lot of information from the tumor itself. So we need really a relatively high amount of tumor material so that we can do immune histochemistry and histomorphology. We need to know the protein expression, such as the PD-L1 status, because if it's a high PD-L1 status, we might want to give pembrolizumab on its own. But we also need to know or have enough material for genomic analysis, because we need to know the driver mutations. So we actually need to have a really high amount of tumor material, and usually we are still doing this with conventional tissue biopsies. And these can either be CT scan guided, as you can see here. In the case of lung cancer, we often use bronchoscopies, and sometimes we do this with ultrasound guided biopsies. But in some cases, we also have to do a surgical intervention in order to get a piece of the tumor that helps us to choose then the right treatment. At this point, I would like to introduce you to a patient of mine who, when I met her in March 2017, was 74 years old. And her previous history, apart from this one here, was actually quite blunt. But in 2010, she simultaneously was diagnosed with an early stage breast cancer and an early stage lung adenocancer. Both were operated on, and since I met her in 2017, everything was fine. But in January 2017, she was diagnosed with pulmonal and suspected adrenal metastasis. And we did a CT-guided biopsy, and what happened is that the patient had a pneumothorax. So this is what you can see on this X-ray here. Basically, you can see these are all the ribs, basically. This is the lung here, and what you can see is that there is air between the lung and basically the rib cage, if you want to say so. So basically, air got trapped here, and this is a potential very life-threatening situation. So what you have to do is that you have to insert a chest tube in order to basically suck out all the air that got trapped here and allow the patient to properly breathe again. And then you leave that chest tube in until basically the injury that was caused to the lung is healed again. And in this patient, actually, she was in the hospital for quite some time, and it was really difficult for us to really treat this little injury that obviously was introduced by the CT-guided biopsy. So when the patient was finally released, she was so traumatized that she actually never went to come to her follow-up with it. And the next time we saw her was with this X-ray. Actually, in almost 2 months later, she presented to the A&E department with shortness of breath. And what happened is what you can see here. She had a total atelectasis of the complete right lung. So what happened is that the tumor actually completely blocked the air ventilation of the total right lung. So at that point, we then did a bronchoscopy, and we were able to identify that the metastases that we saw at the beginning were coming from the adenocarcinoma of the lung. We saw a very uncommon EGFR receptor mutation, and she also had HER2 amplification. This patient, it took really quite a while to convince this patient to come in again and to talk her into therapy, because this initial complication that we caused with the biopsy really took a toll on this patient. At the moment, the patient is on third-line chemotherapy and is actually doing quite well. So what I'm trying to say is that conventional biopsies is risky, and it's something that you really cannot do very often, because it is actually quite risky. And sometimes, because of the location of the tumor, you cannot really get to the actual tumor, because it's in areas where it's very hard to get to. So this is where liquid biopsy comes in. So compared to conventional biopsies, liquid biopsy is actually quite, relatively non-invasive and has therefore less complications. It's actually quite cost effective. If you think about a bronchoscopy, you need patients personal monitoring the patient. You need a neurologist actually doing the bronchoscopy. Sometimes you need anesthetists, because you need really anesthetists to monitor the patients doing the bronchoscopy. So it's actually quite cost effective compared to liquid biopsy. Also, because of these reasons, liquid biopsy allows you to do serial and also longitudinal sampling throughout the patient's sort of tumor history. And liquid biopsy, because it's the things that we are looking at in the tumor, we will look at in the next slide, are represented from all of the different areas of the tumor. It may give us a better representation of the total tumor within a patient. And also, liquid biopsy might give us a better picture of the actual tumor heterogeneity. We've already talked a little bit about the heterogeneity within the tumors. And when we talked about that different patients have different tumors, which is what you can see here. But there are other levels to the heterogeneity which we haven't looked at yet. Because if you can imagine, if you take a biopsy, and this is what you see here, at different sites within the tumor, you can end up with a totally different picture, because in this picture here, for example, you have a dominance of one clone, but if you just go a little bit further to a side, you might have a dominance of another clone. But really, there's a very mixed picture. And also what you have to bear in mind is that the different locations of the tumor might also be totally different. And what's happening, and this is where a conventional biopsy really, I think, has the problem, is that obviously the heterogeneity or the biology or the phenotype of the cancer, of the tumor, is changing throughout the therapy. So we need to understand, and we would like to understand, what the driving clone or the driving biology is of each patient's tumor every time we have a progression. And because of the complications and invasiveness of conventional biopsies, this is really not possible with conventional biopsies. And I believe that this is really only possible with liquid biopsies. So liquid biopsies, what is this actually? What can we monitor? I've already talked a little bit about it. So basically is that we take a blood sample and we analyze in this blood sample derivatives of the tumor. And this can be tumor cells because, for example, the primary, but also the different metastases here and here sort of send different type of tumor cells into the bloodstream, but also in the blood you can look at cell-free nucleated acids, and these can be circulating free tumor DNA, RNA, microRNAs. We can also look at extracellular vesicles. Every cell, whether it's a tumor cell or a healthy cell or healthy tissue, secretes some sort of vesicles. And in these vesicles you can investigate some protein contents or also DNA contents of the cell where the vesicle was released from. And you can also look at tumor-educated platelets or platelets, something that's been recently, there's been very much research interest into this. So different things that actually are incorporated in the term sort of liquid biopsy. Today we'll be mainly focusing on circulating tumor cells. Okay. So if you want to look at circulating tumor cells, it's most often mostly feels like actually looking for the needle in the haystack, because you have to identify one CTC amongst millions of other hematopoietic cells or mononucleated cells. So it's really very difficult. And this is why the detection and the analysis of CTCs usually involves different steps. So in most cases, actually, the first step is that you do a CTC enrichment. And this enrichment can be based on different methods. There are mainly two types of different methods. So there's like a label-dependent and label-independent methods. Label-dependent, with that I mean that you, for example, try to enrich tumor cells based on, for example, a specific marker that they express on their surface, like, for example, EpCAM, which is an epithelial marker. And the cell search system is an example for label-dependent enrichment, and it also enriches cells based on their EpCAM expression. Label independent is that you don't rely on a specific marker, and you look independent and try to enrich your CTCs independent of any surface marker or any other marker proteins. And for this, the parsotic system is an example. And in the parsotic system, the cells are enriched based on their size and on their ability, sort of how deformable they are. So if you have, for example, erythrocytes, they are very flexible and they can basically squeeze through this little gap that you are having here. But tumor cells, they are a bit bigger and also more rigid, so they are getting stuck, basically. So this is the difference between sort of the two main groups that we are having for enriching CTCs. Once you have enriched your sample a little bit for CTCs, you then have to still identify your CTCs. And also for that, there are very different techniques that you can use that are depicted here. We mainly use at the moment are immunocytology techniques, where we look for other sort of epithelial markers, and also to look for hematopoietic markers to exclude these cells from the CTCs, which should have more epithelial markers. And once you then have identified your CTCs, you can do different analyses with the CTCs. You can analyze the genome and find, for example, if they have certain driver mutations. You can look at the proteome with different methods. You can also do RNA analysis to do RNA sequencing, for example. And something that's really exciting is that you could also use these CTCs that you've identified and isolated, and then, for example, transfer them back into mouse and learn more about actually the biology of dissemination, but also use this to understand and investigate different treatments actually in vivo. We did a study, so this is now coming to the immune checkpoint inhibitor part. So we did a study where we looked at circulating tumor cells in non-small cell lung cancer. And we had around 100 patients almost, and we used the label-independent pathotic system for enrichment of CTCs. And after that, we identified the CTCs, as I explained before, based on a higher amount of cytokeratin expression compared to leukocytes. We excluded leukocytes by CD45 expression. We only obviously looked at cells that had a nucleus. This is what the Darby staining is for. And then we also stained for PD-L1 because we wanted to know how the PD-L1 expression of the CTCs compares to the PD-L1 expression that we see in tissue tumor biopsies. And this is an example of the results that we were actually seeing. So here you see CTC, which is because it's keratin positive, it's CD45 negative. It obviously has a nice nucleus, but this one is PD-L1 negative. And this is an example for a CTC that's actually PD-L1 positive. And we had 3 different groups of patients, obviously. So we had a group of patients where we only found CTCs that were PD-L1 negative. We found or had patients where we found CTCs that were all PD-L1 positive. And we also found or had patients that had both PD-L1 positive and PD-L1 negative patients. CTCs, I'm sorry. And what we did then is that we took the patients and from which we had blood samples at the same time point than the tissue biopsy. And we had 30 patients, and in 23 of these patients, we could actually CTCs. And we looked at the PD-L1 status of these CTCs. So basically, this here is the number of the CTCs. And here's the number of the PD-L1 positive CTCs in these samples. And at the bottom part here, you can see the PD-L1 tumor proportional score from the biopsy taken at the same time point. So what you can see here, I mean, obviously it's very difficult because in non-small cell lung cancer, we know this, we have very little CTCs. But what you can see if you look at the patient samples where we have a little higher amount of CTC, that actually sometimes we don't really see an overlap. For example, this patient here, the biopsy revealed a tumor proportional score for PD-L1 of 20%. We found these 3 CTCs, and all of the CTCs were PD-L1 positive. Here's another example. Again, here the biopsy at the same time point when the blood sample was taken showed a tumor proportional score in the biopsy of 1% of the tumor cells being PD-L1 positive, but in the blood, all of the CTCs were PD-L1 positive. This is just basically showing what we see here is that there's actually no correlation between the PD-L1 expression of the CTCs compared to the PD-L1 expression in the tumor tissue biopsy. And this is actually something that is not proving, but goes along the same line with the heterogeneity, that we really think that one single tissue biopsy really cannot represent very well what's going on in the tumor all over the body, and that maybe the CTCs give us a better picture. We're not proving this here, but I think it goes along the same line of this point. And we are also, I mean, because this is still small patient numbers, we are also not the only ones that are seeing these. There are also two different other studies, also from non-small cell lung cancer, different sort of set of patients, and not all of them taking really the blood sample and the tumor tissue at the same time. But all of these studies show that there's really no correlation between the PD-L1 status of CTCs and the PD-L1 status in the tissue biopsies. What we then did is that we had looked at patients where we did investigate CTC numbers at different time points throughout treatment with immune checkpoint inhibitors. So here in this group we had 11 patients, and they were all treated with monotherapy with immune checkpoint inhibitors, and we looked for CTCs before we started the treatment, at the time where we did a CT scan, and the time, like the first CT scan, and at the time when we analyzed when the patient had a progression. So we looked at total CTC numbers, and we also looked how many CTCs were PD-L1 positive. And what you can see that there are three, as usual, three groups of patients. So we have one group of patients that initially responded and were still responding at the time when we sort of had the data cut off. And then we had a group of patients that initially responded but eventually progressed. This is the number of the application when we detected the progression. And we had a group of patients that really progressed immediately at the first time point. And what we could see is that, so this is in black, the number of patients that had a decrease or no change in CTCs, and in light gray, the number of patients that had an increase in CTCs. And what you can see that the responding patient at the time point when they were responding, most of them had a decrease in CTC numbers and also a decrease in PD-L1 positive CTCs. And at the time of progression and in the patients that didn't respond, we saw that, especially when it comes down to the PD-L1 positive CTC, we see that all of these patients had an increase in PD-L1 positive CTCs. This is something from the biology that we didn't really expect to see, to be honest, at the beginning. And we really do not have at this time a really good explanation for this. It might have to do something with EMT, because PD-L1 expression also linked to EMT, and it might be that these are maybe more mesenchymal cells, but at this time point, this really is speculation. But because we had really small patient numbers again as well, we were quite happy to see that also other groups showed similar results. So in this publication and also in this publication, people were looking at PD-L1 expression on CTCs, and when you look really into the data, you can see that they also, in patients that were progressing, see an increase in PD-L1 positive CTCs. And these publications are also for CTCs, but it was also shown in tissue biopsies. This is from melanoma patients, where obviously it is much easier, because in melanoma patients it's really easier to get biopsies, because you can biopsy the skin much easier than you can biopsy a lung cancer. But also in this publication, they mainly looked at the immune response towards the treatment, but they also show data on PD-L1 expression of CTCs, and they could also see that there's an increase in PD-L1 positive CTCs, in PD-L1 positive tumor cells at the time of progression. So I think these are really quite exciting and interesting results, but obviously we need to take this further. We need to investigate more patient sample and also do prospective analysis with that. And this is going a little bit away from the immunotherapy thing, but I want to point out that incorporation into clinical trials is really pivotal. So I think without attaching all this information that we get from early translational studies like ours we really cannot move this any further. And I think that these results are really interesting enough to move them further into further investigation. I just want to show you a few examples about clinical trials with CTCs that are actually going on at the moment. This is from the DETECT study group, and that's actually quite cool. That's breast cancer. And from breast cancer, we know that also we know this from other cancer, that the phenotype of from primary to metastasis can change. For example, you can have a HER2 negative primary, and then you have HER2 positive metastases. So these studies are around whether when the primary is actually HER2 negative, and then when you identify HER2 positive CTCs, for example, as in this case, then they are looking at whether these patients are benefiting from then choosing a treatment that's actually targeting the HER2 compared to giving them standard chemotherapy. So I think study concepts like these are very innovative. This is another example for CTCs or decision making based on CTCs, also from breast cancer. This is not on the phenotype of the CTCs. This is more or less based on the number of CTCs that you find in the blood. Actually, basically, if you find more CTCs, then the question is whether patients that have more CTCs might benefit more from a chemotherapy compared to a hormone therapy. So that's actually really quite cool, I think. And then there's one last point I want to make, and that's this sticking together helps. So that's something that we learned along the line, is that we also, and this is from our study in lung cancer, so not very often, but sometimes we do see CTC cluster. And we know that these CTC cluster, which you see here, where the CTCs are sort of clustering together, patients have, if we can identify CTC cluster in patients, they usually really have even worse prognosis. And what studies like, for example, this study here from Nicola Azzeto and his group could show that sometimes these CTC clusters are accompanied with neutrophils, for example, in this case. And this actually makes the cells even more aggressive and increases the ability actually of the CTC cluster to build metastasis in the lung, for example. But also CTCs are accompanied also, for example, by thrombocytes, also something that we've learned. So in further investigating CTCs, we also have to take all of this into account. So at the end, I hope really made clear that CTCs are really giving us pivotal information about the tumor, something that's really hard to get from conventional biopsies. And also that this information, because we can monitor CTCs and get the information really throughout the therapy, many different time points, that the information that we are getting from analyzing these CTCs really will help us to develop new treatment strategies and also understand resistance better. And we also hope that, and a little bit I could show with our very preliminary data on PD-L1, that this helps us to identify new predictive biomarker. Obviously, I mean, continuous work on CTC detection, CTC enrichment is really necessary, and we also need early incorporation into clinical trials to improve this further. But I really believe that by doing all this, we really can improve, like tailoring personalized cancer treatment and have a better patient stratification to treatment, which ultimately will improve outcomes of our patients, but also will sort of improve the cost effectiveness. And with this, obviously, I would like to thank you for listening to this webinar and me today. I would like to thank the patients and their family for providing us with the blood samples. These are the collaborations and the people that we work with here at the University Hospital in Hamburg-Eppendorf. In the work that I've presented, mostly Franka Kobos, Lisa Marie Böttcher, Sarina Pessler, and Anna Babayan have been working on this. The work has been funded by Cancer ID, for which I'm hugely grateful. And I'm also very grateful for the Hubertus Wald and the Margarete Clemens Stiftung, because they allowed me to actually be in the clinic and also do the research work that I'm really very interested in. Thank you very much.
Thank you for your presentation, Melanie. If you just joined us, feel free to add any questions into the question box and we will answer these in a bit. We are now going to run through a quick poll question. The question will appear on the screen and you will have 30 seconds to pick your response. Which area of CTC application is most relevant to you? Option number 1, CTC biology and metastasis. Option number 2, prognosis. Option number 3, treatment choice and monitoring. 4, discovering new therapeutic targets and resistance mechanisms. Or 5, drug screening and target validation. You have 30 seconds. Five seconds. We now have some time for audience Q&A. So if you'd like to submit a question, please do so in the question box. The first question is, additional to CTCs, could you get data on PD-L1 expression from ctDNA? Over to you, Melanie. Hi, Melanie, can you hear me?
Good. Oh, thanks. Sorry for the delay in my answer. I was actually
Okay.
still muted. That's a very good question. And that's actually one of the reasons why it makes sense to also look at CTCs and why CTCs are actually that important and interested, because you cannot really look at protein expression levels while analyzing ctDNA. So that's something that if you want to know about protein expression, that's something that you cannot, obviously this information you cannot get from looking at ctDNA. I think there are many other reasons why looking at CTCs has become more interested, because I think for a while, because looking at ctDNA became eventually a little bit easier. So looking at CTCs, because the detection is actually a little bit more difficult, was less interesting. But we also now really value more the information that we're gaining from the CTCs, that is the protein expression, but also the CTCs ultimately are the cells that leading to metastasis. So it really makes sense to analyze also CTCs, and you simply cannot investigate protein expression such as PD-L1 by looking at ctDNA. I hope that answers the question.
Thank you, Melanie. Question number 2 is, you used an antibody agnostic technology for enrichment of CTCs. Why?
Yes, that's true. We did. Thanks for the question. We did this for several reasons. First, we knew already that the CTC numbers in non-small cell lung cancer are especially low, and with the method, with the cell search system, for example, which is EpCAM based, we know, especially also in non-small cell lung cancer, that not all of the CTCs and also the tumor cells really express EpCAM. So we already suspected that there are some cells that we will miss just by simply selecting, for example, EpCAM-based CTCs. So by using the pathotic system, this allowed us to look at CTCs really in an unbiased way, which in our case also showed, because we did a little study where we compared CTC numbers from the cell search system, which was EpCAM based, with the pathotic system, which is label independent, and we actually could show that with the label independent system, we could show increased numbers of CTCs. So that's the second reason really why we chose the pathotic system, because it gives us an unbiased way of identifying CTCs, and in non-small cell lung cancer, it also increases the CTCs numbers that we are finding. Another thing is that it's also really cool that we really could find also CTC clusters, something that the research community is really very sort of interested, and a lot of research is going on in this area, and the pathotic system also allowed us to identify the CTCs cluster. So this is why we choose the label independent pathotic system really.
Thanks, Melanie. I've got another question for you. With the heterogeneity you saw in PD-L1 expression on CTCs for some samples, how do you interpret that as a clinician?
Again, thanks for the question. To be honest, really, we did expect to also see the heterogeneity in PD-L1 expression also on the CTC level. We knew from the tissue biopsy that there's obviously heterogeneity in the CTC expression on the tumor cells. But I think what's really important here that the CTCs really will allow us to see this heterogeneity at different time points, because sometimes you give immunotherapy as a second-line treatment, but the biopsy was taking, like, I don't know, a year before. So that's really cool that we could also see the same heterogeneity on the CTCs. And another thing is, and I think this is the sort of showing a little bit the heterogeneity within the tumor actually, and I think that's also what we were trying to show, that really by taking tumor tissue biopsies, you really cannot show the proper heterogeneity within the tumor. So we actually saw this in the heterogeneity, that the CTC PD-L1 expression did not correlate with the PD-L1 expression on the tumor tissues. That was really something that was really good to see in order to prove that there is some heterogeneity going on.
Thank you. Question, the fourth one I've got for you is, what other opportunities do you see for CTCs with regards to supporting you as a clinician in your decision making?
Yes, I think there are huge opportunities in CTC research, also in regards to really influencing my clinical decision making. And I think that's been shown in the clinical trials that I represented to you, where really they investigating whether the detection of a certain protein like HER2 is expressed on the CTC will influence my treatment. And that's really because of the difficulty of the conventional biopsy. I really believe that by investigating CTCs and further investigating the phenotype of the CTC during the treatment, that will really allow us to base in the future treatments based on the information that we are gathering from CTCs.
Thank you, Melanie. You're working with tiny numbers of CTCs due to their rarity. Is culturing of CTCs something of clinical value, and can it be done?
I mean, absolutely. That's something of huge clinical value, and it can be done. So what you can do with culturing CTCs, you can generate circulating tumor cell lines, where you then in culture can investigate from tumor material that you got from the patient. In vitro can really investigate the effects of test different treatments on the patient's material. And what you can also do is like what I explained earlier, you can transplant the CTCs into mice, and then you have CTC derived xenografts. And also in these xenografts, you can investigate the treatment options. So that's really something that would be huge, would be of huge clinical value. And from, for example, from the pathotics system, it's actually quite easy to get the CTC and put them in culture. So that is something that is really cool. I think, however, you need to be honest, a high number of CTCs to do these culturings. And in lung cancer at the moment, for non-small cell lung cancer, that's very difficult at the moment. It works very, very well in small cell lung cancer. Carolyn Dive is working on that, and she's done really good work on that. So, but in the end, it has huge clinical value for us.
Thank you, Melanie. Another question. In the CTC clusters, there looks like always one CTC with large nucleus. Is it one nucleus or a condensed group of cells?
Oh, that's a really good question. It's difficult to say, to be honest. It can be both. I'm not really sure which picture you mean at the moment. Ultimately, to prove that these are really CTCs, obviously we have to pick them, but I think it can be both things. But the real cluster basically are sort of single CTCs sticking together. So these are sort of different cells, to be honest, stuck all together and laying over each other.
Thank you. And we've got time for one more question, and it is, what is the turnaround time for results from CTC?
Oh, I mean, with the methods we are using, that's actually quite quick. So it depends on sort of different fixations you use, but you can have the result either on the next day, like when you take the blood, the patient is in the clinic, you can have the result on the next day, or because we do an overnight fixation of the cells, we have it 2 days later. So that's actually really quick. That's for the PD-L1 expression, that's the time for the protein expression. It'll be 2 days.
Thank you to the audience for submitting those questions, and thank you, Melanie, for your answers and for your earlier presentation. So that is all we have time for. We hope you enjoyed the session. And as mentioned earlier, all unaddressed questions will be passed on to Melanie. So if you do have any follow-up questions or comments additional to questions you've already submitted, please email them to myself and they'll be passed on. So my email address is vanula_lane@hansonwade.com. Thank you all so much for your time, and I hope you enjoy the rest of your day.